Welcome back, guys. In this video, we're going to see about the diabetic ketoacidosis in emergencies. So before going into the topic, I will like to tell you a thing that to concentrate in my voiceover, so you'll have a better understanding in this PPT, because some of the points which are missing in PPT, I will be sharing in my voice too. So obviously, we know the diabetic ketoacidosis is a medical emergency condition that can be life-threatening if it is not treated promptly. So, getting into the topic, yes, it is a life-threatening condition with severe insulin deficiency. So, severe insulin deficiency, which causes zero utilization of the glucose to the muscles and cells. So, obviously, there will be a hyperglycemia. Since there is a zero utilization of the glucose to the muscles and cells, there will be a compensatory counter-regulatory hormones which further leading to the increased lipolysis and increased fatty acid oxidations. So these are the things which takes place in DKA. So it more commonly occurs in type 1 diabetes mellitus when compared to type 2 diabetes mellitus. So obviously I have said before that it is a state of absolute or relative insulin deficiencies. So when these things happens, there will be a concomitant effect of counter-regulatory hormones which are secreted too much. So these hormones includes glucagon, catecholamine, glucocorticoid, growth hormones. So these hormones plays an important role in playing the major three metabolic events, which includes gluconeogenesis, proteolysis, lipolysis. Obviously, gluconeogenesis plays an important role in increasing the hepatic glucose production and decreasing the peripheral glucose utilization. And due to the increased proteolysis, there will be a decreased protein synthesis also. Due to the increased lipolysis, there will be increased ketone production. So going into the next, so obviously the patient present with the symptoms of lethargy. Lethargy most commonly occurs due to the dehydration or electrolyte imbalance. So next, the deep and shallow breathing with fruity odor. This is nothing but a ketotic breathing, which obviously occurs in metabolic acidosis. So next, the patient will have irritable symptoms like nausea and vomiting and abdominal pain, which may be associated with the distension. There will be a no rebound tenderness in this. So it is not an abdominal case. Always the diabetic patient with comes with abdominal pain. First check the urine ketone level and random blood glucose level. And other signs which includes the patient can be normotensive or hypotensive, depends upon the hydration. Next, there will be a tachycardia and tachypnea. There will be a dry oral mucosa and a decreased in skin turgor. So hypothermia or sometimes a fever may be present. Next, the patient will be stupor or focal neurological deficit, depends upon the severity of the decay. There will be a term called severe decay which will be dealt at the last. Next, cerebral edema due to the therapy. It is the iatrogenic cause which can be prevented, which will be dealt at the last. So obviously the decay will not occur suddenly. There will be something which leading to the decay actually. These are the precipitating causes. These precipitating causes will lead to decay. So once the precipitating cause is managed, there will be high chances of preventing the recurrence of decay. So first of all, there will be an inadequate insulin administration, or the patient will be drug defaulter. The patient obviously will be not taking drug, not taking any insulin. So this is the most common cause of the decay patients which are coming to the emergencies. Next, the infection. The patients are taking the medications regularly, but these infections like pneumonia, UTI, gastroenteritis, sepsis, these causes decay as a precipitating events. Then infraction, cerebral or coronary or mesenteric or peripheral, and the drugs which causing or stimulating the decay, which includes cocaine, fluoroquinolones, diuretics, corticosteroids, and SGLT2 inhibitors, and then pregnancies. Next, coming into the pathophysiologies. So, decay. Let us divide the decay component into diabetic ketosis and acidosis. In the diabetic component, obviously, there will be hyperglycemia. So, this hyperglycemia is caused, which further leads to glucosuria. So, this glucosuria, there will be an increased osmotic diuresis in the body and leads to the loss of electrolytes in the body, and along with the volume depletions, this hyperglycemia can cause dehydration. So how come it cause all these things? Due to the insulin deficiency, there is an increase in gluconeogenesis, and there will be a decrease in utilization of the glucose because there is a decreased level of GLUT4 transporter, which plays an important role in reuptake of the glucose in skeletal muscles. Next, there is an increase in counter-regulatory hormones, glucagon and catecholamines, which plays an important role in glycogenolysis. Next, ketosis. So, as an overview, I am saying that the ketosis, due to the increased counter-regulatory hormones and decreased insulin secretions, there will be an increased lipolysis. So, these lipolysis plays an important role in releasing the large amount of free fatty acids from the adipose tissues. So, these things get converted into ketone body and triglycerides productions with the help of CPT type 1 enzyme. Next, what are the ketones which are formed due to these actions? The three type of ketones are formed. One is beta hydroxybutyrate. This is not detected in the urine. And acetoacetate. This is obviously detected in the urine. So we are using the urine ketone strips to detect these things. Next, acetone. Acetone is nothing but a neutral ketone. We are not obviously using this. So initial two are present as the keto acids, and the acetone is a neutral ketone. Yes. Next, beta hydroxybutyrate is not detected by nitroprusside test. That is urine ketone strips. Obviously, we are going to detect from the serum, which is most accurate thing to get measured. So it is obviously used in private setups. Next, acidosis. So coming into the acidosis component, at physiological pH, the ketone bodies exist as keto acid form. So these acids are neutralized by the bicarbonate ions. So these bicarbonate ions, which are readily available in the body, will get depleted and get utilized, which further leads to the metabolic acidosis. This acidosis is also contributed by the concurrent lactic acidosis. So what is lactic acidosis? How it get caused? One is due to the dehydration, which is obviously caused by diabetic ketoacidosis. These hyperglycemic conditions will cause osmotic diuresis, which further leads to dehydration. This dehydration will further leads to shock, that is hypovolemic shock. This hypovolemic shock will cause decreased organ perfusion and decreased muscle perfusion, which obviously leads to anaerobic action in the body, which further leads to the lactic acid productions. Next, the diagnosis of DKA. So obviously, all these must be present to make a diagnosis. First, DKA. D is nothing but the glucose, that is the diabetic component. K is nothing but the ketone. A is nothing but the acid. So bicarbonate levels or pH levels. D. So the blood glucose concentration of greater than 250 milligram per deciliter. So next, the K component. The blood ketone concentration of greater than 2.5 millimoles per liter, or a significant ketonuria by using the urine ketone strips 2 plus, that is the moderate to large. So the third component is bicarbonate concentration of less than 18 milliequivalents per liter, or the venous pH less than 0.3. Next, laboratory abnormalities. Next, in these things we are going to see the value actually. Hyperglycemia, the serum glucose levels, which is 250 to 600 milligrams per deciliter. Next, serum bicarbonate less than 15 milliequivalents per liter. Then arterial pH, which is between 6.8 to 7.3. Serum ketone positive, that is beta hydroxybutyric acid, which is positive. Next, urine ketone positive, that is acetoacetate, which is dealt in the nitropuroside. Urine ketone strips becomes positive. Next, the total body potassium is decreased, but the serum potassium is mildly elevated. So obviously the serum will get, while measuring the serum concentration of the potassium, you will obviously will get the normal value or the slightly elevated value. This is due to the H plus ions, which plays an important role. I will tell about it later. Next, total body sodium, chloride, phosphate and magnesium levels are all decreased. Next, leukocytosis due to any infections or precipitating cause. Serum amylase may be high. This is due to the increased stress of the pancreas, because obviously insulin is not that much is secreted in our body, and there will be a hyperglycemic condition in the body, so which further causing the stress of the pancreas to secrete more and more amylase, so it may be high. So it is obviously not used as an major important investigation actually. So just I'm saying that serum amylase will be high. Next, hypertriglyceridemia, then hyperlipoproteinemia. And there will be obviously an increase in blood urea, nitrogen and serum creatinine. This occurs due to increased proteolysis. Increased proteolysis will cause an increase in the plasma amino acids, which further leads to increase in blood urea, nitrogen and serum creatinine. So next, so what are all the differential diagnoses? Hyperosmolar, hyperglycemic, non-ketotic coma, lactic acidosis, starvation ketosis, alcohol ketoacidosis, uremic acidosis, salicylate intoxications, methanol, ethylene glycol poison, then rhabdomyolysis. So the details of these will be dealt in the next class. So coming into the most important thing, that is the treatment. The replacement of the fluid should be given, since the patient has lost around 5 liters of fluid around due to the DKA conditions, due to osmotic diuresis. So restore the circulation by the fluid therapy as soon as possible. So around 3 liters should be given over 3 hours. So this is a rough calculation actually, so which will be dealt in the further slides. Then treat the insulin deficiencies. Then treat the electrolyte disturbances, such as total potassium level will be less obviously in this condition, so we have to replace the potassium levels also. Then observe and carefully monitoring the patient. So the separate slide I have added for this. Next, detect and treat the underlying cause of metabolic decompensation. So obviously treating the precipitating factor. So this is the table I have taken from the Harrison. So since it is a very small table and unable to see this, we can expand this table in further slides also. So next, monitoring. Coming to the monitoring of the patient, admit the patient first if the pH is less than 7.3. If the patient is having mental status is compromised, there should be a prophylactic intubation also. Next, nasogastric suction should be done, since there is higher chances of aspiration of this patient. You must secure the airway, and nasogastric tube suction should be done, and the fluid can be given over the nasogastric tube also. Next, to monitor the adequate hydration of the patient, you should always put bladder catheterization for output monitoring. Next, ECG monitoring. ECG monitoring will be done Harley documentation with documentation of the QRS interval and T wave morphological appearance. Since you are replacing the potassium, there is a high chances of probability of causing iatrogenic cause of hyperkalemia. So you should document every hour. Next, serum glucose should be monitored, electrolytes should be monitored Harley. So electrolytes is very difficult to monitor Harley. By using an ABG, you can monitor the electrolytes in these days. Next, serum calcium, magnesium, phosphates levels to Harley, and blood urea, nitrogen, creatinine and ketones should be monitored every 6 to 24 hourly. So obviously in this, the key role of ABG, with the help of ABG, you can obviously see the electrolytes value also. Next. So this is the table we have taken from the Harrison. The first three steps obviously we have dealt in the past slides. So that is the confirming the diagnosis, admitting the patient, then serum electrolytes. Okay. Next, coming to the replacement of the fluids, replace 2 to 3 liters of 0.9, that is the commonly used NS bottle, or a ringer lactate solution. Avoid ringer lactate solution in the patient who are having a decreased urine output, or the patient having any history of um, CKD or increased potassium levels you are seeing in ABG, or ECG changes of hyperkalemia. So preferably in some hospitals they are using ringer lactate solution. In many of the hospitals they are using 0.9 percentage NS. So it should be given over the first hour, that is 1 to 3 hour. So how much rate should be given? It should be given around 10 to 20 ml per kg per hour. Subsequently, it should be converted. If you are giving 0.9 percentage NS, it should be converted into 0.45 percentage of the NS at 250 to 500 ml per hour. So just we are reducing the rate of flow after 3 hour. So why we are reducing the concentration of the NS bottle? This is obviously because there will be increase in the chloride levels in the body, which further leads to many complications, hyperchloremia. So after this, change into 5 percentage glucose and 0.4 percentage saline or ringer lactate at 150 to 250 ml per hour. So obviously we are reducing the rate of flow of the fluids when the blood glucose reaches the 250 milligram per deciliter. So obviously the cutoff value is 250 milligram per deciliter in RBS. So when the RBS get reduced to less than 200 or 150 or less than 250, obviously we are going to change into the fluid of choice 5 percentage glucose. The fluid therapy. In this fluid therapy, the primary goal of the fluid therapy is to maintain the adequate circulation, and the secondary goal is to maintain the brisk diuresis. Yes, brisk diuresis. The patient should have the adequate urinary flow. So we have obviously discussed previously that the patient should be catheterized. So also contributes to the hyperglycemia by decreasing the renal clearance. Around 3 to 5 liters of the fluid deficit is common. So this point I have said before. When the hemodynamic stability and adequate urine output are achieved, the IV fluid should be switched to 0.5 percentage saline or the ringer lactate solution depending upon the calculated volume deficit. Then the change to 0.45 percentage NS you are using a lactate, that is the ringer lactate, helps to reduce the trend towards hyperchloremia later in the course of decay. So this point I have said before obviously. Next, the administration of short acting regular insulin. So at what dose it should be given? So IV it should be given over 0.1 international unit per kg. So this is given as bolus. Obviously in various article they are in the new edition of Harrison, it has been said that giving a bolus dose is not needed. You can directly start an continuous IV infusion. So first of all, you should start this actually 0.1 units of, that is 0.1 international units of insulin per kg per hour should be given by the continuous IV infusion. Increase 2 to 3 folds if there is a no response by 2 to 4 hourly. You have to monitor the RBS level every 2 to 4 hour. So if it is not reducing by 10 percentage or 50 milligram per deciliter in 1 hour, obviously you have to twice the dose. So first of all, you have to see the potassium value also. Initially, if the potassium level is less than 3.3, there is no point of starting insulin at first. You have to correct the potassium level, obviously. Since it is hypokalemic, it can lead to arrhythmia, since insulin itself will cause hypokalemia. So in this condition, do not administer insulin until the potassium is corrected. Subcutaneous insulin may be used in uncomplicated, moderate, that is mild to moderate decay with closed monitoring. So this target I have said before. The target is around 10% of the previous RBS value, or 50 milligram per deciliter reduction in 1 hour. If the target is not achieved, then increase the dose by 50 to 100% and the second bolus can be given. And the next, as the glucose concentration decreases, infusion rate also to be decreased. When the blood glucose reaches 250 milligram per deciliter, then obviously you have to decrease the insulin dose and administer dextrose. This point we have seen before, that is D5 should be started after that. Then assessment of the patient. So obviously you have to assess the precipitating factor. What are all the precipitating factor which is leading to the decay condition? And unless until you are treating the cause, the decay is not going to resolve. Next, measure the blood glucose level every 1 to 2 hourly. Measure the electrolytes. Obviously these points we have seen this before. Next, monitoring the blood pressure, pulse rate, respiratory rate, mental status, fluid intake and output every 1 to 4 hourly. Replacement of the potassium, the important point comes over here. 10 milliequivalents per hour when the plasma potassium level is less than 5. So make the point as 5 or 5.2 milliequivalents per liter. Next, administered 40 to 80 milliequivalents per hour when the plasma potassium levels, that is the serum potassium level, is less than 3.5 milliequivalents per liter, or if the bicarbonate has been given, because bicarbonate itself will cause hypokalemia. Bicarbonate usage in DKA is not advised actually. In very severe cases we can give bicarbonate. So regarding bicarbonate, I will be showing the slides in future actually. Next, if initial serum potassium level is greater than 5.2 millimoles per liter, do not, I repeat, do not supplement potassium until the potassium is corrected. Since already the potassium is greater, if you are further giving KCl, there is high probability of condition which is leading into hyperkalemia. If the patient is oliguric, do not give potassium until the serum potassium level is less than 4. In this condition, in this special condition, you have to see the serum potassium is less than 4, or the signs of hypokalemic, that is the U wave which is seen in the ECG. So as the matter of point, the replacement of the potassium is restricted in the cases of oliguric patients or the patients having the serum potassium levels which are greater than 5.2 millimoles per liter, and then for the patients having the signs of CKD, I have tabulated the thing which we have read before, that is the potassium levels when it is greater than 5.2, nothing to be replaced, and there is no need of replacement if the patient is in oliguric condition. You should replace only in the patients of oliguric condition when there is a signs of hypokalemia, or when the serum potassium level is less than 4. Only in those conditions you should replace potassium in the case of oliguric patients. So next, 3.5 to 5.2. Obviously you can replace the potassium levels of 20 to 30 milliequivalents per liter. When it is less than 3.5, additional potassium needs to be given. So which we have seen before, that 40 to 80 milliequivalents per liter can be given. So these replacements should be given very, very slowly, since there is a higher chances of making the patient to sit upon the condition of hyperkalemia, and obviously he will go to cardiac arrest. Next, coming into the bicarbonate deficiency. Obviously, there will be a bicarbonate deficiency due to the increased neutralization of the metabolic acidosis and the lactic acidosis conditions. So, bicarbonate need not to be given in the normal condition. Only in the case of severe acidosis, when the pH is less than 7 or 6.9. In many of the books, it has been given 6.9. So, we can make the value as 7. It is given in Harrison actually. So, around 50 millimoles in 200 ml of sterile water with 10 milliequivalents per liter of KCl per hour may be administered for first 2 hours until the pH is greater than 7. So the bicarbonate can be given only in the condition when the atrial pH is less than 7. So, and it should be given along with the KCl, since it can cause further hypokalemic conditions. So we can read this paragraph that despite of bicarbonate deficient, bicarbonate replacement is not usually necessary. Bicarbonate administration and rapid reversal of the acidosis may put or may impair the cardiac function and reduce the tissue oxygenation and promote hypokalemia. Yes, the results of most of the clinical trials do not support the routine use of the bicarbonate replacement, and one study in the children found that bicarbonate was associated with the increased risk of iatrogenic cause. It is an iatrogenic cause of increased risk of cerebral edema. So my sincere advice that do not give bicarbonate levels. You should always discuss with your consultant before giving the bicarbonate replacement to the diabetic ketoacidosis patient. Next, hypopotassiemia. Oh, sorry, hypophosphatemia. So obviously we are not going to correct the hypophosphatemia, and we are obviously not going to measure, since it is not a life-threatening condition actually. Next, bicarbonate therapy should be given only in the 3 conditions: when there is a severe acidosis, when the pH is less than 6.9 or less than 7, the patient is hemodynamically unstable in the case of pH less than 7.1, the patient with hyperkalemic changes with the ECG. So these are the 3 conditions you can give bicarbonate therapy. So bicarbonate therapy, how it can be given? So the deficit has been calculated with the formula 0.5 into weight in kg into the desired desired bicarbonate levels minus measured bicarbonate levels. So next, the 11th point which is given in the Harrison notes, that continue until the patient is stable. The goal is that to maintain the RBS level 150 to 200 milligram per deciliter, and the acidosis should be resolved. Then the insulin infusion may be decreased up to 0.02 to 0.1 international unit per kg per hour. Once the hyperglycemia is controlled, the body will take around a half a day or a 1 day to clear the ketone. Then the ketosis is resolved. So always after that you have to start the patient in oral as soon as possible. Administer a long-acting insulin as soon as the patient is starting the eating habits. Then next, allow for around 2 to 4 hourly overlap in insulin infusion, and subcutaneous can be started along with that. The resolution of decay can be said when the ketone levels is less than 0. That is the serum ketone levels when it is less than 0.6 millimoles per liter, and the venous pH is greater than 7.3. In government setup, obviously the urine ketone strips should be mild or should be nil. So next, you have to search for the underlying causes. First, after sublisting the patient, you should search for the precipitating events. So obviously it is due to the insulin therapy the patient is not taking, and the infections, so which is preceded by fever and increase in the TLC count. and you can do lumbar puncture for the DKA patient if the highly suspicious of altered mental status in a DKA patient. So if you have the provisional diagnosis along with meningitis, then pneumonia is difficult to diagnose in the patient with dehydration since the alveolar fluid is absent over here, which is seen in exudate. Then acute myocardial infarction, these are the precipitating factors. I have seen a case of myocardial infarction along with the DKA. So next, stroke, then thromboembolic phenomena. Any thromboembolic events. The complications of DKA, hypokalemia, hyperkalemia, hypoglycemia, cerebral edema during the treatment, transient kidney injury, acute kidney injury due to the dehydration, then acute respiratory distress syndrome, then bronchial mucus plugging because the patient will be in severe dehydration state, then atrial and venous thromboembolic events. This occurs due to the repeated withdrawing of the blood and repeated ABG. So the decay with special situations, the decay in end-stage renal diseases, it is relatively rare because the lack of renal insulin clearance will be there. So next, in this condition, if it comes, since it is rare, if it comes, what we can do? No fluid replacement therapy is needed in this condition. Then the dialysis associated hyperglycemia and ketosis can occur without so much dehydration because the inability of the development of osmotic diuresis. Obviously, the kidney is not functioning, there will be no osmotic diuresis, and these things are more common in dialysis associated patients since there will be a high probability of hyperglycemia and ketosis which occurs without much dehydration. So you should not give fluid in this patient. If you are finding any dehydration in those patients, a conservative fluid therapy is given. A safer side of 250 ml of fluid can be given in hypovolemic patients with frequent monitoring. Insulin therapy is the mainstay of treatment for the CKD patients. Start with 0.1 international unit per kg per hour, same to same, what we have studied before. There is a higher risk of hypoglycemia, and then potassium supplementation usually not required because in CKD patient itself there will be a lack of osmotic diuresis. So less amount of potassium loss will be in CKD patients. Then if it is a DKA patient in CHF patients, CHF conditions, fluid management is the main challenge in these patients because already the patient will be in volume overload condition. So you will be replacing the fluid according to the hemodynamic status. Depends upon the condition, whether the patient is in shock, whether the patient is in volume overload condition, or by auscultating the patient, by seeing the dehydration signs. A conservative fluid, safer side of 1 to 1.5 liters can be given over 1 to 2 hours actually. Next, 20% or 25% of dextrose is used for blood glucose maintenance once the blood glucose reaches below 250 milligram per deciliter to reduce the fluid overload because we cannot use D5 for these patients. Since D5 bottle itself, it's a minimum 500 ml. So the assessment of severity, the term called severe DKA, this can be asked in Viva questions actually. In which condition you can say the patient is in severe DKA? Severe DKA is the patient when the blood ketone level, that is the serum ketone levels, is greater than that of 6 millimoles per liter. Then bicarbonate level will be below 5.0 millimoles per liter. Venous or atrial pH below 7. Hypokalemia on admission, that is under 3.5 millimoles per liter. When the GCC is less than 12, oxygen saturation is less than 92, systolic BP is below 90, pulse rate is over 100 or below 60, anion gap, that is the high anion gap, above 16 in these conditions. Euglycemic decay are the condition which are caused by the anti-diabetic drugs actually, that is SGLT2 inhibitors, that glyphosins drugs are the main cause of these conditions. The condition is treated in the same way as the hyperglycemic condition. Obviously, these conditions are the higher probability of hypoglycemia. So you have to see the glucose levels by initially maintaining the glucose levels less than 250 milligram per deciliter is a challenging task in these conditions actually. So for this you can give 10% glucose straight away at 125 ml per hour, because the glucose will be less than 250 milligram per deciliter. So the rest of the things will be same in these conditions. So these are the things I have said before, same to same. So recommendations: reduce the insulin rate of infusion to half when the glucose drops to less than 250 milligram per deciliter. Crystalloids are used rather than colloids. Then cautious fluid replacement in young adults. And then bicarbonate administration is not routinely recommended. Phosphate is not routinely supplemented. Then the rate of glucose lowering should be at least 50 milligram per deciliter. Thank you. So I hope you have understand something about the decay management in the emergency. So I have a plan of posting videos every week. If you are ready, let me know about in the comment section actually. So give some feedback regarding this video so that I can correct in the further upcoming videos. So thank you. Thank you for watching. Like this video and subscribe to the channel for further updates. Thank you guys.